This is most exciting for me. I saw the panel. I was actually walking in the building, and I saw the panel. I said, well, damn. I said, the women are bringing the powerhouses, and us men are being, shunned by this. I said, this is dangerous. I said, should we let this go on? No, this is tremendous. This was something I saw. I was like, I'm really excited about this. Unfortunately, I won't be able to stay for the whole thing, but I definitely wanted to be here. Dawn called me and she said, can you introduce the moderator? And I looked and I said, wow. I said, one of the many powerhouses. I first came to know Dr. Smith, Dr. Teresa Smith, through email, through Zoom, through Teams, during the height of the pandemic. And again, she was always thorough. I got an email from her. I think I had to read it 15 times because she had all the information I ever needed. I didn't need to call her back because I said, oh, it's all here. It's all right here in this email. I got an email from her the other day. I don't think you know I got that email, but I got an email from you the other day that was extremely thorough, and I was extremely excited to be able to introduce the moderator for today's program, which is the what's the title here? Women Scientists panel. And again, the scientists here are phenomenal, just phenomenal. Dr. Smith, I'm going to have to read this because I don't want to miss a thing here. Dr. Teresa Y. Smith, MD, MS.Ed, currently serves as the Associate Dean of Graduate Medical Education and DIO at SUNY Downstate Health Sciences University, overseeing approximately, it says 1,000, but I'm going to be very precise here because Dr. Smith is precise. If I remember correctly, it's 1,010 residents. So I remember her precision, so I wanted to be as precise if possible. 1,010 house staff physicians across the campus. Dr. Smith is also a professor of clinical emergency medicine and works clinically at Kings County Hospital Emergency Department. After completing her undergraduate degree at Spelman College, a fellow HBCU graduate, Dr. Smith attended NYU School of Medicine and finished her training in emergency medicine at NYU Bellevue Hospital. She completed an emergency ultrasound fellowship at none other than SUNY Downstate Health Sciences University, or at the time SUNY Medical, what was our old name? I don't even remember it now. I'm trying to get away from it. Maybe we shouldn't say it as not to remind people of what our old name is. But she completed her emergency ultrasound fellowship at SUNY Downstate and obtained her Master of Medical Education from the University of Pennsylvania. Dr. Smith has spent her career championing diversity, equity, and inclusion in medicine and received the Dr. Dale Blackstock Award in Teaching and Excellence for her demonstrated commitment to advising and mentoring students and trainees. In 2022, Dr. Smith led the institution in receiving the ACGME Barbara Ross Lee, D.O., Diversity, Equity, and Inclusion Award. Again, I don't need to say much more, but without further ado, I introduce to you the moderator for today's program, Dr. Teresa Smith.
Thank you. Thank you very much, Dr. Gwen. That was an excellent introduction, very humbling. And I have the pleasure of introducing the rest of our panelists, some excellent and phenomenal women scientists. We have Dr. Ravi Gupta, who's an astute diagnostician and a researcher in the Department of Pathology at Downstate. She joined Downstate in 2008. Dr. Gupta completed her residency at Tufts University and a fellowship in hematopathology and surgical pathology at Columbia University, NYU Langone Center, respectively. She is the integral member of the Department of Pathology and the director of Hematology Laboratory at Downstate. Her research interests include immunologic mechanisms underlying carcinogenesis in various cancers, focusing on disparities. She's conducted funded research, having received multiple federal grants, including the Department of Defense and the NIH. During the COVID-19 outbreak, she used her knowledge of immunology to focus on the pathogenesis of COVID-19 and published 5 high-impact articles. Thank you, Dr. Gupta. Dr. Tracy Wilson is a distinguished professor of the Department of Community and Health Sciences, the Vice Dean of Faculty Affairs and Research in the School of Public Health. She holds a doctoral degree in psychology from the State University of New York at Albany. She has an extensive experience in design management and evaluation of applied interventions to promote public health and reduce health disparities. And an actively funded research investigator, she has authored over 100 peer-reviewed articles. Thank you, Dr. Wilson. Dr. Carla Booten-Foster is the Associate Vice President for Institutional Equity and an Associate Dean of Diversity, Education, and Research in the College of Medicine. She oversees an array of pathway programs from middle school to undergraduate programs. She developed medical education curriculum on health equity and social determinants of health. She chairs the Health Equity and Social Justice Work Group of the College of Medicine. In addition to her administrative role at Downstate, she teaches first-year medical students, trains junior faculty in research methodology, conducts research in addressing health disparities on social determinants of health, and she sits on several sections of NIH studies. Thank you, Dr. Booten-Foster. Dr. Camacho Rivera. Dr. Marlene Camacho Rivera is an assistant professor of community health sciences in the School of Public Health. She received her BS in Biology and Society from Cornell University, her MPH in Health Policy and Management from Tufts, and her SCM and SCD degrees in Social Epidemiology from Harvard School of Public Health. She was a postdoctoral fellow in the Division of Epidemiology at the Feinstein Institute for Medical Research, Northwell. Prior to her appointment in the School of Public Health, she was an assistant professor of community health and social medicine at CUNY School of Medicine. Thank you, Dr. Camacho Rivera. And finally, Dr. Amy Afable is an associate professor of community health sciences at SUNY Downstate School of Public Health. She received her BA with honors in international relations from Brown University. She received her MPH and PhD in public health from Tulane University. Following her doctoral studies, Dr. Afable was a postdoctoral scholar at the Institute of Health Policy Studies in the University of California, San Francisco. For over 14 years, Dr. Afable has researched, critically examined conceptual frameworks used to understand health disparities and health inequities. Her work has been documented on the declining health advantage with increasing stay among U.S. immigrants and has questioned the validity of the health immigrant paradox. Thank you, Dr. Afable. So I am extremely honored to be moderating our discussion today on some local women scientists who have done really high impact work with COVID-19. I want to reintroduce myself. My name is Dr. Teresa Smith. My pronouns are she, her, hers. And as our equity practice, we have all agreed to address each other by our first names. So I want everyone in the audience to recognize that we are doing this, but we are doing this with intent. So welcome, fantastic women researchers. So let's get started. I'd like each of our panelists to take a few minutes to really talk to us about some of the research they've done in the sphere of COVID-19. So we'll start with Tracy.
And although we have decided to use our first names, I just wanted to note that Dr. Afable, it's just
Afable.
Yes, thank you. So thank you so much for these introductions. I want to thank the Office of Communications and Management for making this opportunity available to have these kind of discussions and space for this. So thank you, and thank you for moderating today. My research in COVID echoes a lot of the research that I've done throughout my career on chronic diseases and chronic diseases that disproportionately affect persons of color, persons of lower socioeconomic status, that affect people by geographic area and by a number of other factors. When COVID started, I think the issue of social isolation and loneliness and its effect on mental health was on all of our minds. And our group started thinking about the populations that we've always worked with and how the social conditions that affect health outcomes, social determinants of health, might create, well, completely predictable that they would create worse outcomes for groups that are always having worse outcomes. So we call these the social determinants of health or fundamental causes of health. And so we started to work together. My colleague Jackie Myers, who is the PI with me on the grant I'm talking about today, Azure Thompson, another professor in the Department of Community Health Sciences, and a number of their investigators wrote a proposal from a larger project here, which I do have to mention since we're talking about women in science, the Max-Wise Combined Cohort Study, a very large epidemiologic study of HIV infection across the country at Brooklyn, co-led with me by Dr. Deborah Gustafson in Department of Neurology. And as part of this work, we were interested in looking at how do patterns of social isolation, that's not having interactions with people, and loneliness, which is that painful feeling that we get when our social connections are not adequate enough. How do patterns of these over the life course affect outcomes in COVID? And specifically, we're looking at mental health diagnoses, depression, and other mental health outcomes, substance abuse, tobacco use, and then control of HIV infection and other comorbidities. So we're able to track over time who became most socially isolated during COVID, how was that internalized into feelings of loneliness, and also look at the large social factors that might account for that. So we're starting from the individual level, looking at genetic risk factors, polygenic risk scores, biologic factors. We're looking at social and demographic factors. And then we're also looking across the United States at how does place, where you live, your zip code, affect loneliness and social isolation, and a number of other factors. So we're looking at the entire picture to look at how loneliness is socially determined. And it is socially determined because populations that are traditionally discriminated against, experience stigma, are othered, are traditionally more isolated, experience stigma, experience self-stigma, and this can lead to these outcomes that may affect increases in substance use, mental health illness, not accessing adequate care for these resources, and ultimately impaired health. So that's the focus, and if I haven't said it really clearly, loneliness and social isolation are very strong predictors, and this is a robust finding throughout the public health and clinical literature, for mortality, for morbidity, and for impaired control of chronic diseases.
Thank you very much. And Marlene?
Again, just like to echo Tracy's sentiments of appreciation. Thank you for organizing this. I'm Marlene Camacho Rivera. My pronouns are she, ella, and I'm a social epidemiologist by training in the School of Public Health. And so all of my research, scholarship, and practice really centers on the role of structural and social determinants of health and how that impacts chronic disease outcomes within systemically marginalized communities. So structural factors being things or conditions related to the built environment, related to the social environment, how our policies and practices operate across systems of oppression, in particular racial residential segregation. And also, importantly, thinking about how broad racial and ethnic categories oftentimes mask many of the health inequities that we see within Black and Latinx communities. And so who is invisible and who is, and what patterns and stories are left untold when we use very broad sort of racial and ethnic classifications. And so the second area of my research is really focusing on elucidating specific populations that are at risk be they for COVID-19 or other chronic conditions, in particular within Black and Latinx communities. And oftentimes we see that these populations identify along other social identities and processes of marginalization. This could include essential workers, it could include immigrants, women, also individuals living within historically disinvested neighborhoods. And my third area of research really focuses on how we can translate the epidemiologic research, qualitative research, and think about how we can put that into action to be able to actually improve and promote health equity. And so a specific line of my research focuses on how we can use community-engaged approaches and structural interventions and social and community-level interventions to be able to promote chronic disease self-management and address chronic disease inequities within urban minoritized communities. That is the research side of what I do. I joined SUNY Downstate in August of 2019, so I was here all of about 6 months before COVID-19 hit, and very quickly had to think about how to transition and pivot much of the work that I was doing with respect to COVID. As a social epidemiologist, we all saw the writing on the wall. Any of us who have lived experiences knew what was going to happen within the COVID-19 pandemic, that the same structural social factors that were perpetuating and exacerbating health inequities were going to manifest themselves within COVID-19 inequities that we saw. And so very quickly started transitioning my attention into looking at, again, groups that are systemically marginalized within society. And so looking at COVID-19 across the continuum, everything from preventive behaviors, vaccine uptake, COVID-19 diagnoses, and also morbidity, mortality, and now most recently, long COVID-19 symptoms, and looking at how social and structural factors influence COVID-19 across the continuum within essential workers, within Latinx communities, and other individuals living with chronic health conditions like cancer survivors, people living with HIV, and other systemically marginalized groups, as Tracy mentioned. In 2021, I had the privilege of being appointed as the Dean of Student Affairs within our School of Public Health. And one of the structural factors that I quickly realized within the COVID-19 pandemic is the lack of infrastructure within the public health workforce and within the health professional workforce, I think, more broadly. And that is not only just the sheer number of public health employees that we had and health professionals at the front lines, but also the diversity of our public health workforce, because we know that diversity makes us all stronger. And so I was able to, in my capacity as Dean of Student Affairs, be able to partner with some of the amazing, folks at Downstate. Carla Booten-Foster is one of them. I see Dr. Daniel Zosaze in the audience as well, to really be able to think about strategies to combine research and training to strengthen our public health workforce and our health professional workforce. And so part of that work has focused on training grants to SUNY Downstate, our clinical research scholars training program, which Carla will speak a little bit further about, which really, again, brings clinicians and allied health professionals into public health, specifically health equity research and practice through an anti-racist and culturally informed trauma frameworks and trauma-informed frameworks, and also our Downstate Public Health Scholarship Program, which really has a specific focus on addressing health equity, tackling COVID-19 inequities, and emergency preparedness by recruiting individuals from systemically marginalized and disenfranchised backgrounds into the public health field. Thanks.
Thank you. Ravi?
My name is Dr. Ravi Gupta, and my pronouns are she, her, and hers. And thank you very much for inviting me to the panel. So during the March of 2020, when COVID hit New York, Downstate was declared a COVID-only facility, and all the clinicians were frantic because we had so much of inflow of these patients. And we knew nothing about that disease because New York was the first city that got COVID. So what I think was an amazing collaborative effort that all clinicians did was we all came together from different departments, from internal medicine, division of cardiology, pulmonary, critical care, infectious disease, pathology, emergency. We all got together and we said, because we are in this place at this time that we can actually describe what this disease is, and that will not only be helpful for downstate, but for rest of the world. So we got together, we followed 1,000 COVID patients that came in for a diagnosis, and 500 of them got admitted, and then we followed them with all clinical pathological features, laboratory findings, and their outcomes, and then we published that study. It was one of the seminal studies at that time, and which actually described the comorbidities and the mortality in low-income group areas and in underserved population. Till that time, there was only sort of an assumption and a talk about worse outcomes in these areas, but we put hard numbers with our study, and we talked about how comorbidities was the most important risk factor for these areas, and 95% of our population actually had comorbidities. And comorbidities are like hypertension, obesity, diabetes, chronic renal failure, et cetera, which is very high as compared to other places. So that was an important study and very remarkable study. Just to follow up on the other studies that I usually work on immunology, and I did more immunological studies on patients with COVID, and actually one of our groups discovered that there was a ligand on lymphocytes that were dying because of COVID. And we found a drug that could go against that ligand, and we actually got approval by FDA to perform a clinical trial at Downstate. So it is amazing how Downstate is so supportive of the efforts of its investigators, that it sponsored the trial. We did it on patients at Downstate, and we had a very successful trial. And we were able to cut the days of symptoms to 3 days from 15 days for people who did not get drug. So I'm very thankful to Downstate and the support that we get from them to accomplish, together what we decided to do. Thank you.
It's fantastic. Wonderful work. Thank you. Carla?
Hi. Good morning, and again, to echo what my colleagues have said, it's truly a blessing to work with this group of dynamic scientists, public health and clinician scientists. So I'm Carla Booten Foster. My pronouns are she, hers, and hers. And my research has always been focused on health disparities for a number of years, but admittedly, as given all that was associated with COVID-19, my research it had to pivot. It had to pivot toward more intentionally focusing on health equity and not only health disparities. And the distinction is that when we think about health disparities, we often focus on the communities that are impacted or the marginalized and minoritized groups that are impacted. And the narrative that's created is that this group is more likely to have this condition. But when we anchor it toward health equity, we're able to see what are some of the upstream factors, the systemic and entrenched factors within our education, healthcare, political, socioeconomic systems that contribute to these downstream disparities. So my research has focused on intentionally and strategically working within health and education systems to advance equity while addressing disparities. And some of the research that I've done has been to create health equity frameworks, or rather to propose health equity frameworks that are based on constructs that Marlene mentioned: anti-racism, structural competency, intersectionality, trauma-informed care, and also community engagement. And to propose these frameworks as a lens through which we can see what we do, what we say, and how we do it. So one area of research was really developing frameworks that can be used and adapted by other systems to advance equity. Another area of my research is focused on how do we advance community engagement, and I see my colleague, Dr. Marilyn Fraser, in the audience, is how do we advance community engagement through an equity lens, making sure that there is equitable distribution of resources, that also the way in which we think of communities. The COVID-19 pandemic had such a disproportionate impact on communities of color So really focusing on community and understanding the definition of community, not just as a locale or a zip code, but really the interactions that occur within the community leaders, the community voices, who do people listen to during times of pandemic. And as we saw that as much as the medical and pharmaceutical system was making advances in multi-million, billion-dollar vaccines, that it really took community leaders to increase vaccine confidence. And we had an opportunity to recognize that and to share that message with students and faculty. Marlene and I were working with Dr. Susana Morales, who developed this program to educate community leaders, to empower community leaders by building up the public health workforce. So it was really great working with Dr. Morales. And lastly, Marlene mentioned this. So we're more anchored toward equity. We understand that we need multiple frameworks to advance equity, but we need people who are going to do the work. People with lived experiences, people who were doing health equity research before it became a thing. And it is so important to invest money and time in nurturing and growing a talent of health equity focused scientists at SUNY Downstate. So I've had the honor and privilege of working with Marlene, Dr. Daniels Asaze, I saw her here, and Dr. Marilyn Fraser also, and Dr. Marcus Lambert, to obtain grants, NIH and HRSA-funded grants that increase opportunities for researchers, scientists of color, scientists who really come from a diverse background with diverse perspectives to really provide the training. So that's really been the focus of my research, to intentionally put in place programs to advance equity in clinical practice, in education, and community engagement.
Wonderful, thank you. And I'm going to correct myself, Dr. Amy Afab.
Thank you so much.
Yes, Dr.
Yes,
Afable.
yes. Thank you, Teresa.
Yes.
My name is Amy Afable. My pronouns are she, her, and hers. And again, I want to thank my colleagues that are here that are part of the panel, as well as the Office of Communication that helped organize this and led the organization. I want to acknowledge and I want to build on what my colleagues here have been saying, although my current research doesn't directly study the epidemiology of COVID. It's not very COVID specific, but what my current research does is really try to address head on some of the fundamental causes that address the inequities that we observed during the COVID pandemic. As I think Marlene, my colleague, mentioned, this is for those of us, I would sort of classify myself as a public health scientist, but those of us who have been studying health disparities or health inequities for decades, and I may not look it, but I've been studying it for a long time, it was not a surprise what we saw. And what we heard from Ravi about the impact of COVID on those with comorbid conditions, in particular chronic disease, which our local community suffers disproportionately from, it was really, it came as no surprise, and unfortunately it was a tragic observation, and it was unfortunate that it took COVID to sort of reveal the realities of inequities that exist in our society. So I just want to make that point. So COVID really allowed me to sort of focus, or maybe even pivot a little bit more on systems change and developing interventions that address some of the fundamental causes. But before, I don't want to go into too much detail about the projects that I'm working on, but I do want to acknowledge my collaborators and my community that work with me on the research that I do, that sort of inspire me. And some of them are here in the audience, Dr. Marilyn Fraser, Arthur Ashe Institute for Urban Health. I also co-lead projects with Dr. Christina Pardo. She is the head of the Division of Health Equity in the Department of Obstetrics and Gynecology, as well as Dr. David Kaufman. He is in the School of Health Professions in Medical Informatics program. So I work, and finally, the Department of Family and Community Medicine, Kiki's here, Dr. Montgomery Douglas as well. So I want to mention all those colleagues because I do work closely with them. And so what I do is sort of a reflection of sort of a learning process as well as a collaboration, right? So currently, I'll comment on 3 more recent projects that, as I said, address really systems change and directly address some of the fundamental causes that we're dealing with, that were revealed during COVID, which are the digital divide, social determinants of health, but really the manifestation of social determinants of health in individuals' daily lives. And when I say that, we all know that education is a determinant of health. We all know that poverty is a determinant of health. But how does that really manifest in the individuals that we serve, right? And so, for example, we all mentioned that Central Brooklyn is disproportionately affected by poverty, disease, mortality. But what does that mean for the patients that our physician collaborators see, as well as the communities that we work with? It means that they may not be coming to the clinics, or they may not be engaged in healthcare. And so that by the time that they get into the clinic or go to see their doctor, it may be too late to be able to prevent something quite tragic, or perhaps even death. And so one of my projects focuses on really trying to address the daily survival needs of patients that come to see the obstetrics, pregnant patients that come to University Hospital at Downstate. And that project is called We Care About Brooklyn, and it focuses on really trying to understand why Central Brooklyn is the epicenter of the maternal health crisis here in New York City. We have really high rates of severe maternal morbidity, and that occurs among women of color who are of Afro-Caribbean origin primarily. And so what that project does is it recognizes that perhaps housing instability or food insecurity that pregnant women, particularly pregnant immigrant women of color, may be struggling with on a daily basis. We recognize that may actually serve as a barrier to continuous engagement in care. So what we do is we try to support those women by directly asking about what their daily survival needs, and we try to address it with a community health worker support, as well as referring women to the types of support they need to address sort of these daily survival needs. And the goal of that project is really to ensure that the women can continue their care and enter prenatal care early enough so that we can avoid a severe maternal morbid or even a death prenatally or in the postpartum period. So that's one project I am working on. A second project really addresses the digital divide and the whole idea of digital medicine, telehealth, and we are working with community advisory board called the Digital Equity Community Advisory Board, which is called DECA. And the goal of that is to really understand what are the experiences of our community with regard to using technology. And so this project is really specific to stroke survivors, and its goal is to really manage blood pressure and delay a stroke recurrence. But that said, I think it has larger sort of applications, because we're going to the community, we're asking them what kind of technology they're using, do they use, what are they familiar with, what are they comfortable with, and so we're really trying to directly address this concept of digital divide. Does our population, even though they're disproportionately affected by poverty or perhaps disease and mortality, what are they interested in? Are they actually using it? And so we're collecting data to see what kind of needs they have, and whether the technology we're using, which is a remote blood pressure monitor as well as a telehealth tablet, whether that is acceptable to this population. And then, because we want to be able to at least manage blood pressure and obviously prevent stroke recurrence. And the third project that I'll mention briefly, because I don't want to take up too much time, is the Brooklyn Health Equity Index. And this is really a Central Brooklyn-wide project. And as I mentioned earlier, my colleagues at the Arthur Ashe Institute are really critical to this project, as well as colleagues at the One Brooklyn Health System, which is one of the larger safety net health systems here in Central Brooklyn. They're very much engaged in this. And really, this is a CBPR's community-based participatory research project where we go into the community, we ask community how they define equity themselves. We're in the process of using that data that we've collected. I think we collected over 10 focus groups and 20 key informant interviews. We've used that data to develop an 11-item index, which we would like that index to be used by health systems to understand how well they're doing in terms of addressing equity. And so we're only in the pilot stages of looking at the equity index data, but the goal is to have, obviously, Central Brooklyn systems use this metric, but hopefully have all of New York City and other systems nationwide advocate and use that system metric as well. So we'll end it there.
Excellent, excellent. It makes us very proud to work at Downstate. You all are fantastic scientists, and it should be recognized, not just women scientists, but fantastic scientists at large. So I want to start talking about delving into topics of your research, really trying to address our community, our workforce, and some of the impact that your work has had on all of us. So at the height of the pandemic, we had the lockdown, and we can all recall that there was several months of isolation, particularly social isolation, which in of itself led to detrimental impact for vulnerable patient populations, particularly in the care of their physical and mental health. Doctors Jacqueline Myers and Bernice Porges of the Department of Psychiatry and Behavioral Sciences co-authored a study discussing stress and coping activities for those at risk for alcohol use disorders during the pandemic and isolation. Tracy, can you talk to us a little bit more and describe your work with the vulnerable patient populations and the impact of isolation that the lockdown had?
Sure, I'd be happy to. Thank you for that question. And I forgot earlier, my pronouns are she, her, hers. So there are many determinants of substance abuse issues, mental health issues. Some are biological, some are.
I think we can't hear you.
Can you hear me?
Yes, that's better.
Okay. Some are biologic, some are social, many are socially structured, and but there is a theory that a burden of mental health to some degree and substance use actually is related to feelings of, again, many different things, but loneliness and social isolation are two of them, that these are coping responses to feeling like we don't have enough of these social interactions that support us and make us thrive. This is different than social support, having people who can watch your children if you need to go to the doctors or can help you pick up a prescription. This is a feeling, almost a painful feeling, and in the literature we see that these two ideas of isolation, the amount of contact you have and the quality of it, and the feelings of loneliness cannot be discussed in the same way. They're two separate, what we call constructs or variables, and they're not very highly related. For those of us in this area, there's about correlations are around 0.3, maybe up to 0.4, depending on the population. And so what we're seeing is that many of us enjoy solitude, right? We can be without social connections and do fine with us. Many of us can be surrounded by many people who love us and feel lonely. And it is the loneliness that is intervenable. There are evidence-based interventions, but they're small, they're fragmented. And so what we're really trying to understand is what drives patterns of loneliness over the lifetime. And many of the things, like we've all talked about, that are very predictable from the literature, early childhood trauma, stigma and discrimination based on gender, based on sexual identification, based on HIV serostatus or other stigmatized conditions, create feelings of, or result in feelings of loneliness that then translate into coping with through substance use, alcohol use. We've also seen it translated into less physical activity. It's also, I mean, we could go on and on. It's one of these things that are associated with many different outcomes: food insecurity, lower medication adherence, less engagement in medical care overall. And so what we're hoping to do in this research, by having a really nice longitudinal design where we can track loneliness and social isolation for about 6 years before COVID hit, and during this era, and moving forward for the next 5 years, to sort of see how these social conditions, the social structures, the social relationships, and the individual factors, once COVID hit, you can think of it as a shock, right, to everybody. Who had the most adverse outcomes? And then I'm very interested in resilience and about really making sure we're looking at community assets. Carla mentioned, and all of us have mentioned this a little bit. Who does best in these circumstances? So we're using a community engaged model and employing this longitudinal design with what's called a mixed methods approach. So we're collecting longitudinal qualitative data with the endpoint to sort of see what are the causal connections between our social structures, our social relationships, substance use, mental health, engagement, and care. But with the critical piece being, how can we design community-informed interventions that are feasible to implement and that can increase and promote better outcomes in the populations that we are working with and serving?
It's extremely important, and I think, you know, some of what you're describing, and some of what all of your work is describing, is that, you know, the pandemic first highlighted the health inequities and the predicament circumstances of vulnerable populations that already existed, but exacerbated by, you know, what became of during the height of the pandemic, the isolation, the inability to access appropriate mental and physical health care. So I had the opportunity, I want to switch a little bit talking about our workforce. I had the opportunity to publish a paper with some emergency medicine residents who were fantastic. We really looked at how the pandemic impacted the residents, their training, their working environment, particularly at the height, those first couple of months. And we found that, you know, during this time of uncertainty, the connection with each other, with their administration to understand, when you could understand what was going on, was extremely important. We did a qualitative analysis and some focus group with some of our emergency medicine residents. Marlene, I know that you are starting a project with some nurses that were on the front line to look at their impact, particularly around how organizational policies and the organizational structure, which, you know, providing that structure and that certainty can be extremely helpful. Given the fact that we're going to chronically have to deal with the next disaster, the next virus that comes about, it behooves us all to learn from what we experienced in the pandemic. So can you please talk to me a little bit about your workforce work?
Thank you for that question. I think as a social epidemiologist, I recognize that that occupational status and occupational categories and employment was one of the most important and salient factors to really look at in the early on in the COVID-19 pandemic. And so when we as public health professionals and health professionals were making recommendations around COVID-19 preventative behaviors, who was able to stay at home? Who was able to work from home, who's able to socially distance, and quickly realizing that essential workers, and I come from a proud family of essential workers across a variety of different occupations, I'm married to a frontline healthcare worker. And so this was something that was very at the forefront of my lived experience and has been, since childhood. And so I was really interested in again, really focusing on individuals who were helping to maintain our society and keep our, economic systems open, our healthcare systems, functioning, while many of us had the privilege to be able to work remotely and stay at home. And so I, along with some wonderful colleagues within the School of Public Health, Doctors Elizabeth Helsmer and Janet Rosenbaum in the Department of Epidemiology and Biostatistics, as well as Dr. Paul Landsbergis, who's in the Department of Environmental Occupational Health Sciences, we were awarded a pilot award from SUNY to be able to look at COVID-19 impacts broadly in healthcare workforce, in frontline healthcare workers. And what we were able to find, this was in the very beginning of the COVID-19 pandemic, is that many of the again, social determinants of health that we knew were going to play out were very much playing out within our essential healthcare workforce. And so we saw very high burdens of mental health symptoms, anxiety, depressive symptoms being reported within our healthcare workforce. Burnout was very quickly becoming an issue, as well as other social determinants around financial hardship, loss of employment within a household, food insecurity within a household, as well as in particular among women, challenges with disruptions in childcare, and how disruptions in childcare and disruptions to our educational system, again, were all interconnected and playing out within our workforce. And so through that pilot funding from SUNY, we were able to focus on our frontline nurses within New York State. And so what we know within the COVID-19 pandemic is that the deaths within our frontline healthcare workers were grossly underestimated and undercounted. But from the data that we were able to obtain, we know about 1/3 of deaths within our healthcare workforce were within our nursing workforce. And so very quickly decided that this was a population that, again, needed their voices and experiences to be lifted and centered. And so this study is funded by the CDC through the National Institute for Occupational Safety and Health. And again, it's a mixed method, both quantitative and qualitative study, to be able to look at the experiences of nurses throughout the COVID-19 pandemic. And we are still in a pandemic. I know that people want to move forward from that, but that is not the reflection of our nurses and our healthcare workforce. And what we've been able to see, I can mention a bit within our qualitative work, is that nurses were really playing a very important role in, directly communicating some very day-to-day, hour-to-hour changes within our organizational policies and safety policies, communicating that to patients and their families, and that led to a lot of frustration, that led to fear. In many cases, that led to being threatened within their workforce, or being perceived as threats because they themselves were being perceived as transmitting COVID-19 infection to patients and families, rather than being folks who were always serving in a role of caring and serving as healers. The mental health impacts are still, being experienced and seen through this day. The social isolation, many times having to distance themselves from their families and their close social contacts because they were working, tremendous number of hours, and they themselves did not want to transmit COVID to their families or their friends. And so recognizing the isolation. But there were also and that the organizational factors and the organizational environment really did make a difference. In our qualitative work, what they were able to identify is that having a supervisor, having an immediate director, someone who was able to understand the unique conditions, in some instances be able to task shift or shift responsibilities, especially for people who were considered high risk, pregnant persons, individuals who were immunocompromised, so being able to shift responsibilities, making sure that they had adequate access to the PPE that they needed, and just being able to provide spaces for them to be able to be able to vent, to share their fears and frustrations and concerns were incredibly important. But they also recognize that there's a call to action, that there needs to be change, that in spite of their best intentions, their best efforts, and the efforts of their immediate, their organization or immediate supervisors, that nursing workforce is they're understaffed, they're underpaid, they're undersupported, and so having organizational change to be able to recognize safe nursing and patient staff to patient ratios, recognizing the ability to be able to make sure that adequate protections are still being implemented in cases where that mental health supports are being acknowledged and provided to workers. And of course, compensation and other types of resources that are going to address social determinants of health, like financial assistance, like food insecurity, like adequate child care are going to be critical for us to be able to bolster in our preparation for the next pandemic.
That's wonderful. It's extremely important for us to be able to use our hardships for the better, to be able to change the infrastructure that perpetuates much of the problem, particularly in our community and in our hospitals who are under-resourced. So thank you very much for that. That was fantastic. So it's well documented the Black and brown communities all over the United States suffered the most morbidity and mortality from COVID-19. Ravi, can you please share with us some of the comorbidity factors you found that increased mortality, particularly in our patient demographic, and what your research population did to find that was protective? And what other studies have found that have been protective?
The highlights of our study of the 1,000 patients that we started to screen and 500 inpatients that had severe symptoms of COVID, we at least upfront gave them, our mortality was much higher, was about 46%, and the reported mortality is about 21 to 35% in rest of the studies. So that really gave hard numbers on the increased mortality in low socioeconomic areas and underserved areas. And I think the most important thing, and I already discussed that comorbidity is one of the most important risk factors for higher mortality and worse outcome. What I think the most important thing that we established was it is not the race. We had people of non-African American race specific here, and across the races, the mortality was the same if they came from the same area. So it is not the race, it is actually just the living conditions in the underserved areas that they live in, and that what my colleagues have been talking about, that is actually a worse risk factor because it gives rise to the different comorbidities and just a living structure. And the interesting thing that just to resonate on what Amy is doing research on women and how they have experienced worse sort of health outcomes in central Brooklyn, what we saw was that the women patient actually died earlier than male patients. It seems like women were brought to the hospital in a worse condition than males were. So, there's such a interesting revelation from this study that people wait to bring a women to the hospital when they have severe symptoms than when they wait for men. So I think that was, I thought, something that I found very disturbing in the study. And the rest of the things that we also found that within 3 days, one-third of our patients died. So the doctors had to be very aggressive when the patient come in and not wait to start treating those patients. So those were the important sort of highlights of the study. Another, really no protective, at that time really there was no treatment for COVID, and really vaccination was not on board. So I think at that time everybody was just isolating, so really no protective measure available except isolating.
Very interesting, very interesting. And I think it just talks about the dynamic of the family, right? And so oftentimes the matriarch of the family has to take care of others before they take care of themselves. So extremely enlightening. The COVID-19 pandemic highlighted, as we've said over and over again, what we already know, that health inequities exist in our healthcare system, which impact Black and brown communities at higher rates in their ability to maintain physical and mental health. They are entrenched in neighborhoods that are, exacerbating both political and social determinants of health. The pandemic was just an extreme example of what already existed. Carla, can you please talk to us about the Syndemic framework and how we should view community-engaged research given what we experienced with the pandemic?
Thank you for that question. It really builds on what Robbie was talking about, the comorbidity that was observed in communities of color that contributed to worse COVID outcomes. So the whole Syndemic framework, as I was working with community partners from the Jackson Hart cohort study, which is the longest and largest cohort of African American cardiovascular disease longitudinal study based in Jackson, Mississippi. We were talking about the community, the role of community, and this pandemic. And we were reflecting on, this is more than just a pandemic. We're not talking about a singular event here. And it was important for us to really look at the totality of impact and all there was consumed within this pandemic. So we started looking at the literature and identified works by Merrill Singer and colleagues looking at syndemics. And the syndemic framework consists of basically three concepts, and one is having a disease, a condition. So we would say SARS-CoV-2 here, the virus causing COVID. But then this singular condition interact with other factors that we could call comorbid conditions in a way that is not only additive, but somewhat multiplicative, synergistic and exponential in its impact. So it's not, 1 + 1 = 2. So if you have SARS-CoV-2 in someone with underlying cardiovascular disease, underlying diabetes, and conditions that are associated with a heightened immune response, and you add to that something that further contributes to inflammation, you wreak havoc. And so you have the COVID virus plus comorbid conditions. But the third element is this underlying pervasive social, political context in which these conditions exist. So that's what the Syndemic framework does, that it takes away from a singular entity, that we're talking about COVID as in the US, it was not just a pandemic. During COVID, we had people dying. We had people with underlying chronic conditions dying. We also have police brutality and murder. And all of that, when we think about COVID-19 in our communities, that's what we think about, in addition to the virus. So the Syndemic framework allows us to really look at what are the factors that come together and interact in such a way that their outcomes are worse than any individual entity itself. And that is really critical when we're talking about community engagement and community research, because we have researchers who focus on, and that's the way we are as researchers, and our funding is siloed on cardiovascular disease, cancer, mental health. But when you think about communities of color, it's all three and then some. So the Syndemic approach allowed us to come together with communities to look at factors that collectively contribute to poor health outcomes, and starting to develop, as Amy liked to say, co-create solutions that can affect all of the above, rather than having siloed intervention on one factor or the other, but really recognizing how as the isolation and loneliness that Tracy was talking about, in someone with underlying cardiovascular disease, in someone without sufficient social resources, that contributes to significantly more significantly worse health outcomes. So the Syndemic perspective allows us to look at the cumulative, exponential impact, synergistic impact of multiple social, biological, political, environmental factors that come together and really just exacerbate health outcomes in our communities of color.
Yeah, it's It's enlightening, and I just want to reiterate the work that you all are doing is groundbreaking in our community, but really nationwide, right? In many of communities that look like ours. Amy, can you please talk to us? I think this is a perfect segue about the Brooklyn Health Equity Index and how we can use this tool to more clearly articulate the social determinants impacting our patients.
Yes, thank you. And before I begin, I forgot to mention my other colleague here. Carla is also a big part of the inception of this project. So I'm sorry I didn't recognize you earlier. I just want to make sure I recognize everybody that was on the panel. So it has taken a life of its own, I would say, the Brooklyn Health Equity Index. We had a little bit of funding the first few years from New York State Health Foundation, who I will give kudos to because they've been so supportive with just giving us the initial support as well as, allowing us to prolong it in some way. But really that was funded in response to everything that we've been talking about that was revealed during the COVID pandemic, the inequities, as well as the structural challenges that we're dealing with that are the fundamental causes of these health disparities or health inequities. So the question is, how are we using the metric? So I think, the importance of this project is that it doesn't rely on one researcher or a small group of researchers to understand, to look at the peer-reviewed literature to see, okay, how have other research groups approached the development of a metric of health equity, right? It marginalizes the academic community and puts forth the importance of the patient and the community. What is the community? How are they defining the community? And so when I originally introduced the project, it's a really large community-engaged participatory research project because we didn't want to go to what we knew, right? We wanted to go to talk to community members. And so the first phase of this we took very seriously. We made sure we sort of covered every type of stakeholder in central Brooklyn, from the patient, we interviewed and we had community listening sessions with patient advisory councils. We talked to community advocates, we talked to community leaders, but we also talked to our own healthcare colleagues, the colleagues that we work with, some of the colleagues at Downstate. We talked to students as well, residents that are learning about healthcare and, obviously learning to care for the populations that we serve. So we wanted to make sure we were diverse with regard to the type of voices we were listening to. And we wanted to represent as much of central Brooklyn as we could. And that's why I think it's so unique, because it is a large intersectoral collaboration of, as I said, One Brooklyn Health System, SUNY Downstate Health Sciences University, and Arthur Ashe Institute for Urban Health. So I think that's what makes it unique, because the index, which was developed, was directly informed by what the community was telling us and the diverse stakeholders that we talked to, what they were telling us. And so that paper will be forthcoming. We're working on sort of a manuscript on the results of that first phase, that first qualitative phase. But as I said, it did directly inform a survey or an index measure that contains 11 items that reflect what the focus groups told us, what the key informant interviews told us, right? And so some of those dimensions are things that we've heard about. So we have a question on discrimination, we have a question on wait times, we have a question on provider empathy. So if those that clinicians here are probably familiar with the Press-Ganey metric or the Press-Ganey survey. So we started this project with knowing that the Press-Ganey measure does capture sort of QI or quality improvement initiatives or progress, but we want to be different from Press-Ganey and directly ask about items that perhaps past measures or Press-Ganey doesn't measure. So we do have items, as I said, discrimination, wait time, etc. But we also have new items that that are not contained with it. In particular, as I said, we ask about provider empathy. We ask patients about whether they thought that their provider recognizes how challenging it is to follow their medical advice, right? So we ask questions about whether the provider recognized other social determinants of health that or other sort of basic survival needs that they're dealing with. And so we ask new questions that past metrics have not looked at. So we're happy about that. And another dimension I think is very important is not just discrimination, but stigma associated with patients' physical condition, for example, obesity or some conditions that they get pigeonholed in because, and they're sort of siloed into that area. So we're excited about it, but again, the goal is to reflect the patient voices and use that to categorize systems based on how well they address equity. The goal of it is to have healthcare leaders, systems leaders to really adopt it, and then perhaps even healthcare payers sort of pay attention to it and maybe use it in reimbursement models. So I hope that addressed your question.
Yes, it did. It was very thorough. Thank you very much. I think that's, again, you can see how everyone's work, without us even actually knowing each other on a professional research level before today, but everyone's work builds upon the next. And it's very exciting that this is all taking place here at Downstate. So absolutely wonderful. I want to take the next maybe 10 minutes or so to talk about our careers and how we all got here, which is definitely a feat. So just to give out some statistics in gender and women in science, nearly 43,000 scientists currently are employed in the United States, and about 43% of those individuals are women, and that's actually increased since 2010, when it was about, I would say, 20% were women. So we are, over the last decade or so, trying to increase more women in STEM. The race breakdown is such that it's 53.2% are white, 26.3% are Asian, 9.8% are Hispanic, and 6.5% are Black. So we really do need to increase diversity in the sciences, as many of you are trying to do in your different academic titles. But if we look at the wage gap, which is always very disheartening, but it's important for us to acknowledge that white scientists have the highest average salary compared to other ethnicities, and Hispanics have the lowest average salary. By age, I think that the statistics by age is probably not as important, but to say that from 2010 to 2021, the number of male scientists actually decreased by 4.31%, and the number of women scientists increased by 4.31%. So we are nearing gender equity. We have a far way to go for actual racial equity, and an even longer way to go for the pay gap. And so with that said, you brilliant women doctors, scientists, have broken the glass ceiling and achieved some amount of success within your careers. Please identify what you believe has helped you achieve your success in academics, whether that be mentorship, sponsorship, funding, opportunities, and if we could just take maybe about 1 minute each to answer that question, starting with you, Robbie.
I'm a faculty sponsor of research in my department. So I've helped about 20 plus women physicians, junior physicians in my last decade that I've worked here. And mentorship is very important to physicians because we learn by practicing an apprenticeship model. And I mentor them. I understand that we have to advise them. But what I think is more important is sponsorship, that you really have to make place for them so they can actually rise. So that's what I believe in. And the advice actually to women becomes even more critical because not only you have to advise them professionally, but women have to do this work, professional life balance. So there is always this extra layer of advising that they need as they move on and how to help them prioritize their life and professional career. So that, and I have to say my own life journey has been helped by many mentors. Some of them probably are here, and both males and females, I must say that, and I'm really thankful to them. And as I continue to mentor these young professionals, I hope that they continue this virtuous cycle of, helping other professionals.
Thank you.
Robbie, yeah, I would agree. Mentorship is central they're important, but I want to also begin with, you have to have conviction in yourself, as a scientist, you really have to really know that you're passionate about it, and you have to have the wherewithal to be able to stick with something that might be challenging and insurmountable at times, given everything that Teresa, that you mentioned. So I think conviction in yourself, in your curiosity is important. And of course, that's supported by, that confidence is obviously nurtured by the mentorship around you. And so I agree with Ravi, yes, informal mentorship is great, but I come from a wonderful, I would say it's the gold standard of mentorship programs at UCSF, University of California, San Francisco, where I was a postdoctoral fellow, and they had a very robust mentoring network, which is, till today, I still have 2 or 3 mentors that have opened up opportunities for me when I first began my career in this area. So I think, as I said, both males and females have helped me, but there has to be a recognition that, there has to be a dedicated sort of plan or structure to mentoring the next generation of female leaders and female scientists.
Thanks, Amy. I just want to add one other statistic, if I may. Well, it's not a precise one, but these disparities that you mentioned are really important to keep in mind. And so many of my colleagues, we need another session to talk about what a whole group of people are doing to advance early stage mentorship at the university and to close the gap in representation. But even though that gap is narrowing a bit at the early stage, if you look at the data across the career life course, the number of women who would identify as Black, Latino women are a very, very small percent of the women, well, of all persons who make it to a full professor level. So that squeezes once we get to that level. And there's a lot of things we need to talk about. What I'd like to say is, having been on both sides of it in the career long enough, I have, of course, always, I've had so many amazing mentors. If you're here listening, I hope I've told you that. And, I've learned along the way because I've paid attention to what has helped me and maybe what hasn't been so helpful. And so I would add that we have a lot of knowledge about how to mentor and build. We still have to deal with all of the less tangible things, right, as we're building mentorship. But I would say, in addition to taking advantage of formal mentorship structures, find your people who are at senior levels, who are empowered to help you, who have the careers that you want. And then among those people, find the ones who do not see this as a piece of pie, as something where your success might take away from someone's. Find the people who your success is their success. Mm-hmm. And then when you get to and advance through your career, be that person and pay it back and be intentional about all of the ways that your path has helped you to get to where you are, and be an advocate, because all of our work, I mean, I know everyone here is just, you're amazing, and hearing it all together is fantastic. But if you think about the combined work and all the other people who are not at the table today at Downstate doing amazing work, the body of work is going to advance health outcomes. It's going to promote public health. It builds a stronger institution. It builds a stronger culture where there's greater representation in science. And so we all need to embrace the importance of being intentional about seeking out meaningful mentorship and learn how to be good mentors and have intentions to serve in that capacity as you advance in your career.
So I'm not going to echo everything that my colleagues have already said, but yes, I agree wholeheartedly that conviction, values, and passion is important, as well as mentorship. I'm a social epidemiologist, so I'm always going to go back to systems and structures. And there are no shortage of brilliant women in society, in particular Black and Latina women, because we were talking about equity, not just gender equity, but racialized gender equity. And what's missing are environments and policies and processes that really enable them to take advantage of opportunities. And so structuring institutions, healthcare systems, academia, so that it really does center on equity to be able to advance women scientists is important, and been in environments that have really, walked the walk, and very fortunate to be here with two of my mentors and at Downstate, where I feel like it's an environment that really does that, where you're able to succeed, and have been in environments where I haven't been as successful. And the difference is not me, I think, as a scholar. My training hasn't changed. My lived identity hasn't changed. It's what are the policies, what are the processes, what are the systems that are in place that are going to provide the resources in order to be able to succeed. So how does that show up with respect to faculty recruitment, retention, advancement? We talked about pay equity for scientists. That's just one small piece of the puzzle. You need a lot of support to be a successful scientist. So research support, administrative support, as well as having clear policies around tenure and promotion that are actually going to be able to help women scientists advance within academia. And so I think that, looking towards institutions and having them reflect back on their policies and practices are incredibly important to making sure that women are able to advance within academia.
And I don't know if I have much to add. I agree. An important aspect of my career has been my mentor, Mary Charlson, who was my mentor and my boss and my division chief, and she continues to be my mentor. And she did, just as you said, Ravi, she continues to be a sponsor and a coach. The other thing that I think has been helpful to me personally is being very flexible and forgiving of myself and what I can do and what I can't do, which means I am not going to be able to make all of the early morning meetings. So Marlene and Marcus and I will have meetings Sunday afternoon, right? I'm like, okay, after church, I will be there, right? Sure. We've had meetings Sunday afternoon, 5 o'clock. Marilyn and I have had meetings. She's, I'm in Florida and she's in Texas or somewhere, and we'll talk. So, and because, this work-life balance, it's not always 50-50, and there's a give and take, and really learning to be flexible with yourself and having colleagues who understand that, this is not going to happen. This is not going to happen right now, and we need to reflect and take time out, and doing it with a group of people who are like-minded and who have equal passion. And that research is not a job, I don't think, for any of us. I think it's what we live, what we breathe, what we do all of the time, and having that understanding that the work that we do is going to hopefully surpass us all and continue to live on. But in order for us to continue to do it as long as possible, we just have to be very flexible in what we do. And, one of the things I tell my medical students is, don't take yourself so seriously. The work that you're doing is incredibly serious, but you know what? Someone else could probably do what you're doing. So while you're doing it, enjoy the moment. Learn as much as possible. Meet as many people as possible. Come up with research grants that may not get funded, but you're doing it and you're having fun doing it. Because it's a journey. I think like anything else, research is a journey, and it's something that's best done together. I know there's a quote that says that somewhere, but I could not do any of this without the women here. I think I've worked with every single person here. Ravi, I started with you, and then pushed me on. You're like, get out. So none of this is done alone. None of this. So it's the mentorship, working together, but also, being able to just like relax. My kids would say chillax.
Yeah, I wanted to comment on that. Is it? Yes. No, Carla, I totally agree. Flexibility is key. And as we had all mentioned, we're women, we're caregivers, and that manifests sometimes in poor health outcomes, as Robbie demonstrated. But to help us with the work-family balance, I have to reference my colleague Marlene. We have to change institutions, right?
Yeah.
And so at this, so I've been in arrangements where there are formal structures that protect faculty, mentors' time. And I will say that's not always a common thing to come by. I mean, I think institutions have to start recognizing that, that the mentors themselves need the support, the protected time to be able to seriously mentor in a longitudinal way, female mentors or female advisees or, students or junior faculty. So, I want to push the envelope. I think, yes, we're all flexible. We all recognize everybody's family life balance, family work balance. But I feel institutions should also recognize that and make it a little bit easier for us to balance that as well. And so, building on sort of Marlene's structural change, I think there has to be more recognition of that.
Yeah, well, I think it's an excellent way for us to end this wonderful session. I just want to give everyone here a round of applause. Sorry we didn't have the opportunity to take the audience's question, but I think we learned quite a bit, and I'm sure that you covered quite a bit of range of questions that may have been asked. And it was an excellent way to end to say that we now, as leaders, as scientists, at an academic institution need to help build structures where other women, scientists, physicians can come behind us to excel even beyond what we have done. So thank you to Dawn Skeet Walker for putting this panel together. It's been excellent. An excellent celebration of Women's History Month and an excellent acknowledgement of the phenomenal work that many of our scientists and physicians are doing here at Downstate. Thank you so much.